Okay, so I've been asked to give you the state of the science and directions for future science in 5 minutes. So I will do my very best to be brief. And I'm not going to cover things that I think are shared understanding. Do I have a, let's see. Okay, there's the clicker. Great. And specifically in the first 3 years of life. So beginning in the prenatal period and in the first 3 years of life, we are incredibly plastic individuals. We take in all kinds of information. We are learning machines. And we are learning machines from the fetal period to the last days of our life. So this is not something unique to this period, but in this period, we are taking in information about what kind of world we are in. What language are we going to speak? What kinds of relationships are there? What kinds of nutrients are available? What kinds of stressors are present? And that begins very, very early, and the brain and body respond to those cues. So we know from lots of research about the nature and extent of the disparities that we have in health, and they accrue according to a couple of key demographic features. So we know that socioeconomic position is highly related to health outcomes, and that's true in countries where there are huge disparities and in countries where there are fewer disparities. It's a gradient, a linear gradient. We don't know, though, just by those facts what drives it, because knowing something is connected to socioeconomic position does not tell you what factors are accounting for that, because socioeconomic position encompasses so many different features, including low resources, discrimination, psychosocial factors, and the things we've been talking about in terms of resource instability. We also know that adversity, stressful experiences, and adverse experiences, sometimes collectively called trauma, have long-term effects, and that's potentially particularly problematic when those adversities occur in childhood and in early childhood. There's a big science base about all of that. You might have seen or heard very highly publicized information about how socioeconomic position relates to early brain growth. This data is from the first few years of life, so the first about age 4, looking at total gray matter volume, but there have also been studies that go out to age 20, looking at surface area related to socioeconomic position. Again, this does not tell you what is going on. It does not tell you what characteristics of experiencing poverty have anything to do with the way the brain grows and develops. But it certainly does tell you that there are differences. We also know that there are differences in health outcomes by race and gender. And you might find that if you dig into that data, it's a little more complicated than you might expect, but there's almost an 11-year difference between Hispanic females' life expectancy and Black male life expectancy. So a 10-year difference is pretty dramatic. There are interactions between when adversity occurs in the lifespan. So the combination of early life adversity and adversity in adolescence, or early life adversity and adversity in adulthood, has more damaging effects for health than adversity experienced at only one period. This is probably because we have many sensitive periods in development where we are open, particularly open to understanding the way the world is. So if in your early life and then again in adolescence, your body and brain receive the signals that it's a high threat, low resource environment, that has more sustained impacts on the way you organize your development than it does if they're only in one period. So the program we just heard about talks about providing coping resources in advance of adolescence. I think that makes a lot of sense, because then if kids hit a double insult, they have maybe some more preparation for handling that. So again, it's never too late to support communities and individuals, although early experiences can be particularly impactful. We have a good model, a good adversity model. We understand how adversity gets into your body, into your brain, under the skin is the way it's sometimes referred to. But I would point out that this adversity model is a deficit model. It talks about how adversities change the way your brain grows, the way it develops, contributes to negative behaviors, contributes to all kinds of health conditions down the line. An adversity model can be helpful. It can help us identify where things go wrong, but it doesn't give us all the pieces of information that we need. This is some features of the adversity model that I won't have, of course, time to explain to you, but we've uncovered some things about the differences between chronological and functional age. Exactly how do stressful experiences get into the body? How does it change your endocrine system? How does it change your brain? We know a fair amount about that. So if you want to get into that literature, you certainly can, and I would encourage you. That's where I spend a lot of my time. We have not done as good of a job of understanding resilience. So we talk a lot about the fact that 6 in 10 people who experience 5 or more adversities in early childhood are likely to have depression. What about the 4 in 10 people who didn't? So what are the characteristics of those individuals and their contexts? What could we discover by paying attention to those folks? There has been some progress using a toxic stress framework, which puts the focus on the context and away from the event. So what kinds of supports and relationships are available to individuals when they're experiencing stressful experiences. However, I would say that still includes a fair amount of adversity focus. So trying to think about the biology of protective mechanisms, I think, is where we need to move next. And there are a lot of gaps, and hopefully you can ask questions and we can talk more about that.
Thanks, Sarah.